I will preface the session by saying that we've gotten an admirable number of questions. We also have some coming from the stream, the webcast. So I don't think we're going to get to everything, but we'll try to cover. And if we can be brief, let me start with kind of a lightning round question of what do you all do outside of a clinical trial without a specified washout for patients who are transitioning from EGFR TKI to chemo? And then relatedly, how often do you continue the TKI? Is it, you had alluded to not routinely, but maybe we can just go down and you can offer your thoughts.
So even if there's no trial available, I always try and do a repeat biopsy if it's possible and the patient's willing, and then I would start chemotherapy and continue the TKI they've been on.
So I've recently changed my practice on repeat biopsies. Until recently, my feeling was that I didn't have a clinical trial for which it was applicable. I didn't have a research study that patients might altruistically get a repeat biopsy for. And I thought that the incidence of transformation to small cell was too low to justify the risk and discomfort of biopsy. I think that's changed rather dramatically with the advent of the third generation TKI trials. Which we'll learn more about in the EGFR breakout session, but the gist is that they work really well. Almost all, I think there's only one trial of those out there right now that doesn't require T790M. Maybe there's a second one I'm not thinking of, but the gist of it is that I think that now with the advent of these trials of a drug that really works, that I need to know if T790M is present, I'm starting to certainly do it routinely for EGFR mutation, perhaps at this point a little less for ALK, but I suspect that will also change in the future. I think, Jack, you also asked about interval to...
Yeah, the washout period.
The washout. So I alluded to this a little bit earlier. My feeling is that 3 days was the fastest flare that the Memorial Group saw in their series. The half-life of erlotinib is 8 hours. And so my practice by common sense has been to do a washout of just 2 days when going from standard of care TKI to standard of care chemotherapy.
We routinely rebiopsy folks, and then when they've developed progression, we continue the TKI and add chemotherapy to it in every patient.
Okay. And my approach is also more often than not to continue the TKI. I don't do that invariably in someone who has very significant progression that's diffuse, but more often than not, it'll follow a more indolent or limited pattern in my inclination. If I feel that patients, as in the slide you showed that I had done, that looks like they have less of a tumor burden than they started with, it seems to me that there is a benefit to continuing the TKI. Other questions that have come up include ones like, if someone has had a dose reduction, common, especially in patients who have an EGFR mutation, but we have some patients on crizotinib who do a dose reduction. Any value in raising the dose back up? I don't know if anecdotally or there are any data to speak to this.
So I'll say for EGFR, I almost never re-escalate the dose of Tarceva. I feel like it's generally a good reason that we did the dose reduction in the first place, and I've never found it useful to escalate the dose back. I have a lot less experience with, and I'll say that with EGFR, I feel like dose is a lot less relevant. The maximum tolerated dose that we use in lung cancer is designed to hit wild-type EGFR. Mutant EGFR has a much lower target concentration, so I think dose is less important. For ALK, I think it's a little bit less clear, and particularly with crizotinib, and I don't have as much experience to say whether a low dose is sufficient, and so I sometimes will go back up on the dose.
My answer is essentially the same. In the context of EGFR, there are too many way more promising things to do than to go up on dose. And in the realm of ALK, I agree, the data is still early, but perhaps the same principle holds with the second and third generation ALK inhibitors available on trial. When those are available, it's just so much more promising than going up on dose that I don't think I've ever done that in practice.
I'd like to turn to the question that has come up in a few of the people had specified questions, and I've had it on the website as well, of is there a value to combining EGFR TKIs, which I think is kind of similar to dose escalation, or as we've already alluded to some of the second or third generation EGFR inhibitors that may be particularly effective for T790M, should we be combining them with first generation TKIs, or should we be doing them earlier? My sense is it's similar to the dose escalation question, really, as a separate question from should we be giving the third generation inhibitors as first line therapy is a different one, but there's no demonstrated or even really theoretical value to adding Tarceva to Iressa. You're just going to get combined toxicity, and it's really the same thing as dose escalating, which, if you're not hitting the target properly, you're just going to not hit the target properly with higher toxicity.
With 2 TKIs, I think that's true. Well, I think maybe Dr. Johnson's going to speak about adding afatinib and cetuximab together, 2 drugs that inhibit EGFR both, but they're different types of drugs. One's an antibody, and we've seen some great responses with that.
Okay. One question is about the status of the Vanderbilt acquired resistance trial with erlotinib. What's the status? When are results expected? My sense is that's been slow to get off the ground, and it's not coming anytime soon, unfortunately. I think the IMPRESS trial is going to move along further, and we'll have results from that, which I think we'll be able to generalize to some degree about. But I think that's been a slow process. We've been interested, my center, in participating, but I don't think that's speeding along. I don't know if you guys have any other.
There's a couple of different points. I think, Jared, you were mentioning that while this idea of continuing the EGFR TKI and adding chemo looks like from Dr. Goldberg's data, retrospective data, that it might improve the response, but it might not necessarily change the duration of time people are on drug. And I think that's what this prospective trial will really help us sort out. But different from response, progression-free survival, I think is this issue that Greg and his group really discovered of these flares. I mean, for me, the main reason to keep people on the TKI is not so much to improve the PFS of the chemo, but to prevent the flare, especially if they're not going to respond to chemo. I think this flare is something that should not be underestimated. In your paper, Greg, I think it was that the definition of flare was that people either had to be hospitalized or died, and those are 2 things, and 25% of people did that within a median of 1 week.
Right.
So,
and the thing we always like to emphasize is that study that Alicia is referring to is patients who are going on clinical trials. So this isn't patients who weren't doing so well. These are patients who are gearing up for clinical trials.
I agree that's personally I would say that the flare issue is not as typically that severe in 20 or 25%, but I think it's a less extensive but real issue in a sizable proportion of patients. And I agree with Leisha that a significant part of the reason that you're keeping it going is to keep from some rebound, whether it is enough to lead to a drop in performance status and hospitalization, or just to keep new nodules. And because I think that part of the reason that there's a difference in response rate and progression is that some of those people who stopped the TKIs had 2 new nodules show up that precluded them from being responders to chemo, just because new nodules means you're not a responder. People have asked about the significance, what is acquired resistance and keeping the TKI going, and one of the analogies I think of is like your brakes are failing and you're on a hill and it's going down slowly, but if you take your foot off the brake, you're going to roll down a lot faster, basically, and I think that's the way I think of it. Other people have asked about how confident are we that the secondary mutations are present de novo versus somehow evolve in the evolutionary process of a mutating cancer over 10 months or 2 years.
I think they are present, and so I'll say two things. One thing, I don't think it really matters too much whether they're present at the beginning or not. The second is that I think they are present, and the reason I say that is because a cancer nodule we can see on a CAT scan, much less one that causes symptoms for a patient, is billions and billions of cells, and cancer cells are unstable to begin with, and the chance of that one mutation being present at the beginning it's almost 100% chance that every mutation possible in that tumor cell exists from the start.
Other thoughts on that or no? Okay. One of the questions had been for brain relapse, is it that the drugs don't get in at all or they don't get in as effectively? People can chime in, but I would say it depends. There are responses to brain metastases that have been seen and documented as early as the first approval of IRESA with some impressive brain responses. So we know that even with IRESA and Tarceva, which are not great at standard doses of getting into the brain, you can definitely see good clinical and radiographic responses. Crizotinib doesn't get in the brain, we think, to any appreciable degree. On the other hand,
I think it actually does. I think crizotinib does get into the brain, and in the original phase 2 trial, there were patients with brain metastases who did respond to treatment with crizotinib. So it does go, but you're right that the duration of response is short, and it's less meaningful than with EGFR inhibitors.
I mean, really, a lot of this is based on we just don't have that much evidence. I mean, when I say it doesn't seem to get into the brain to any meaningful degree, that's based on a very small amount of work that looked at cerebrospinal fluid concentrations compared with blood concentrations and showed really, really low levels in the CSF, the fluid around the brain. And we so frequently see brain first or brain only progression on crizotinib that that's a vexing issue. And on the other hand, with the EGFR TKIs, we do know that you can get responses to standard doses, but many of us, if not all of us, will do a different schedule for patients with brain metastases or leptomeningeal disease and go up to 600 every 4 days or 1,000 or 1,500 milligrams a week of erlotinib and see some sense of response.
That leptomeningeal case might, particularly with EGFR, might be a special situation that's worth at least briefly mentioning. Leptomeningeal disease is when cancer gets into the lining of the brain. There's sort of two lakes in the brain that let out into a river that flows down into the spinal canal. And when cancer gets into that fluid and into the lining of that fluid, it's really bad. The prognosis in general with cancer, just about any cancer, is very poor, and it can cause all kinds of neurologic symptoms. And in general, our mantra for years has been that in solid tumors, including lung cancer, that nothing works. But there have been a number of reports out about what Jack was alluding to, pulse dose erlotinib, so giving a higher dose at a bigger interval. So either 4 times the dose every 4 days or a week's worth at a time, something like that, that you actually penetrate that space, that the drug clearly gets in there. And actually had the privilege of co-authoring a piece on GRACE with one of my patients who was diagnosed with leptomeningeal disease, was put on hospice. His wife made him get a second opinion. I'm sure a few people in the room can relate to that. And we put him on pulse dose Tarceva, and he got a year of very high quality life out of that, despite leptomeningeal disease. And a few of my colleagues have reported this in the literature. It's a very real phenomenon. That's sort of a special case that should be treated aggressively. The other thing to point out is that this old idea that the blood-brain barrier, that nothing gets past it, is increasingly being broken down, that there are new drugs particularly designed to get there, that I think you're going to learn more about some of them today. And even some of our old drugs, chemotherapy, we're getting reports coming out on posters and minor presentations about how some of our older drugs actually can have brain responses sometimes.
Several questions about repeat biopsies, and really, at this point, are they soon becoming standard of care? And I would ask that about first EGFR and then ALK. What's your thoughts on this?
I think it's a rapidly changing landscape. I mean, I think that with two drugs, the Clovis compound and the AZ compound, both having breakthrough status from the FDA and hopefully both coming to a drugstore near you in the next year, then,
Specialty drugstore.
This is going to be something that patients will have to do at every oncologist's office in order to get access to these drugs.
And
should do,
that's another question is, is this something that if you're in the community, is it going to be possible to do? And I think the answer is yes, it's the same process that you'd be pursuing for the initial diagnosis, although I think that if you see progression in an isolated area, it may take more skill to isolate that. Thoughts? Go ahead.
I do think for most patients who've been on a targeted therapy with successful results and then develop resistance, that it is something very worth thinking about. But if you're going to go through it, it probably makes sense to do it in a center that does a lot of them and that does research on them, at least today. And this crowd, obviously, by virtue of traveling to this meeting, is kind of aware of this idea of traveling to get opinions. But I think until we have a drug that's FDA approved, it may not be the right thing in every oncologist's office. But my view is that it is the right thing for every patient to do, to travel and think about it.
It's our general teaching in medicine is don't do a test if you don't have something that's going to change the outcome based on it. So if the answer, no matter what the result is you don't have, it's not going to change your management, there isn't a value. But that is rapidly changing with the advent of T790M agents, directed agents that are A, commercially available hopefully soon, but B, are certainly available through clinical trials, and there are other clinical trials. The small cell transformation, uncommon but possible, is cited as one reason. A question came in, bone biopsies, is that, how feasible, difficult is that for acquired resistance?
It's not as useful because when they biopsy the bone, as you know, the bone is a very hard structure with calcium deposits, and in order for them to put it into the paraffin wax and have the pathology machines be able to slice through and put the tissue on slides, they have to put on a decalcifying agent, which is usually hydrochloric acid, which completely destroys the DNA and your ability to do genetic testing. So bone biopsies are not something that we would recommend if the goal is to do genetic testing. If you're just looking to see is there cancer in that spot on the bone, then you can do a bone biopsy, but genetic testing, no.
I would add one caveat to that, which is that some places are particularly good at managing bone metastases, and you can do it with something called cytology, where you don't need to decalcify, and it can be done, but on a routine basis, absolutely what Leisha's saying, it's not going to lead to the molecular analysis that you want.
Briefly, the other thing to note is that lung biopsy is getting much easier, much safer, much more comfortable than it ever has before, particularly with the advent and popularization of interventional pulmonology services, where through bronchoscopy, so a scope down the trachea or the big breathing tube, there are all kinds of new techniques like navigational bronchoscopy, where a really experienced interventional pulmonologist can get almost anywhere they want in the lung, get a biopsy, and do it with much less risk than before.
But it's worth noting that that is a new generation, and they are coming out, but not every place has that, and it's not the same thing as your closest pulmonologist. I work at a center that has one of those people who is very busy and going to be busier with all the repeat biopsies, looking to get a second, but all of the other pulmonologists around town send their biopsy, anything other than the most routine stuff, to this particular person, and it is a specialty procedure, so that's very valuable. Now, another question comes in about what if you have progression in the form of pleural effusion, but there's really not much disease. And I think that the question is two parts. One is, can you do genetic testing on the pleural fluid? Yes, absolutely. You can do what's called a cell block, spin down the fluid to get cells and do tissue from that. But another question is, if you see what you both alluded to as just a little bit of progression, we do routinely or very often hold off on changing any treatment based on slow, modest progression. And I don't think kicking the can is quite the right thought process, because that sounds like we're, deferring because we just don't want to think about it. But sometimes that's a very thoughtful, best approach of active restraint is really, I think, a good one. But the issue is, you don't necessarily biopsy at the first hint of progression, but when you have a good target to get to, correct?
I would say I only biopsy when I'm going to make a change. When I've decided I want to change therapies, that's when I do a biopsy.
And I agree. I actually was going to make that point too about the kicking the can. Sorry, Jared, but I think that
New joke next time.
Kick the Jared.
I think that despite the explosion of new therapies, we only have so many therapies in our armamentarium, and it's not a sprint. It's not a race to see how quickly we can go from therapy to therapy. It's the opposite, actually. This is a marathon that we want to attack, and you have to be strategic, and you have to try and squeeze as much goodness out of each therapy that you're on and make a smart decision when it's time to move to the next one. But you're not looking to do that as quickly as possible.
I very much agree. Like, this is especially true in patients with these mutations where we're really trying to be thoughtful about how to sequence these. We never want to discard a well-tolerated therapy too early. And we're hoping to have people live from treatment to treatment to treatment over a long period of time, which is a much different way of thinking than we had 10 years ago about advanced lung cancer. And now we can fortunately think about it as a much more chronic disease if we do it right. But there are not so many treatments that we should ever be cavalier about moving from one to the other until needed. And I think that's really the big question about why don't we necessarily do the third generation agents up front. It could be that that's the best way, and Jared had mentioned that one trial is not requiring T790M, and that is a first-line trial directly comparing the Clovis CO1686 to Tarceva in the first-line setting. But that's an open question whether it's better to do that than get all of the span you can get out of Tarceva, because there's people in this room who have gone years and still are, and then can still get something on top of that, and we haven't defined that, versus doing third generation agent, progressing on that, and then not knowing what you've got after that. Another question that did come in is, if you do progress on Clovis or AZ's new agent, is there a value in going back to Tarceva or Iressa? I don't think that's been done. I don't think that would be particularly attractive. I don't know if anyone's tried it.
I think it's too early to know. I mean, the number of people who have progressed on these therapies is still quite small. Mm-hmm. I think what is really important is to get a biopsy so we can learn, about how people progress.
I would say there are more promising approaches clinically than going back to a first generation TK after a third generation. Sort of speculating, which is kind of what we do for a living, based on a combination of the science and common sense, I don't see a reason why it should be likely to work.
And going back, because there was a question about flare, in patients who have a bad flare reaction, is that somebody who is predisposed and you would definitely keep on an EGFR TKI pretty much indefinitely?
That's the way I always approach treatment of EGFR mutant lung cancer. Is I say they always should have an EGFR inhibitor. Okay. Period.
Yeah, as one of the few people you're going to find in our world who don't routinely continue the TKI, I do monitor people very carefully when they come off, and yes, if they flare, they stay on TKI forever.
Well, a few more questions, and I apologize that there's an admirable pile here that we just won't get through all of it, but wanted to turn to the heterogeneity question. One question that came is, you have T790M as something that we have a treatment for, you test a lung nodule and it's negative. Do you then go for a liver lesion or some other thing? Do you just keep poking at something until you find what you're looking for? Or is there a sense enough that if you've done the repeat biopsy on one of a handful of lesions of progressing disease that's a representative sample?
I'll let Leisha do most of the answer to this, but I would say that biopsying a couple times is probably a reasonable choice. And I would emphasize that we're looking for, say, this T790M as an example. We're looking for it But every test is different in terms of its sensitivity. You know, Alicia showed data from their institution that shows that there's 50% rate of T790M, and then showed our data that says it's 60%. And we all have the same patients, and it's the same disease. So the difference in those two may be related to the test that was run in on that given set, or just the confidence intervals. But I think there are a lot of factors there, so it's not unreasonable, and it's not, you know, just grasping at straws to do a repeat biopsy of another site.
But not 6.
Probably not 6.
Yeah.
Yeah, we have to be reasonable. I think we're in a little bit of an artificial time period right now where in order to get some of these drugs, you have to go onto a clinical trial and you have to meet the criteria for the trial. So a lot of times we are bending over backwards to try and find a way for patients to get access to these drugs, and we may be doing multiple biopsies. But I think what Greg said is really important, is that a lot of times it just has to do with the test that's being run. The test that is required for a clinical trial may be different than another test that is available somewhere, and we have plenty of patients who are negative on one test and positive on another off the very same biopsy. And I think when these drugs are more widely available, it'll be an entirely different paradigm about who to give them to, and we will see benefit in people who are quote-unquote T790 negative, and is that just because the test was a false negative or the biopsy was in the wrong spot to show it?
Right.
We'll learn about this going forward.
But it's important when you have drugs that will come out at a significant price point that will probably lead the payers to say, okay, well, we will cover T790M, but we will not cover this for... And they probably will not just open up the doors to anybody who wants it.
Very good point.
Also about liquid biopsies, which potentially have the benefit of, theoretically, a greater sensitivity of, you know, any of your lesions that is shedding the DNA. One had asked, what are CTCs? That's circulating tumor cells. But can you speak to the actual practical availability of the testing today versus timeline before it's actually a broadly applicable approach?
There are several, dozens of different research platforms looking at both CTCs and circulating free DNA. There's only one, at least as far as I'm aware, only one kind of FDA-approved test, which is the Veridex platform for CTCs, which is not, it can sometimes detect genetic mutations, but it's not the best platform for many reasons to look at genetic mutations. So I think the reality of today's world is that there's not a blood test to look for EGFR or T790M, but there are dozens in development, and many of these new drugs are looking at, you know, companion diagnostics that may be blood-based. So, you know, we'll get there.
Clinical trials, many of them do include a component that is looking at serum for that. So it's not today, but it's not 20 years into the future. It's probably, you know, 2-3 years into the future, I think we're looking at.
It's publicly known that there are a few companies expending significant resources to commercialize these assays, and so I think we'll get there.
And, you know, with the issues we have, it's not leukemia where you can just do a blood sample to get the biopsy readily. So there's a ready incentive there. You know, yes, there are more interventional pulmonologists and there's interventional radiology, but it's not as easy as phlebotomy. And so it would certainly behoove us, especially if we get the new incentive of, you know, potentially repeat biopsy at every point of major progression. It would be much less cumbersome to do a blood draw than repeat biopsies in the liver or lung all the time.
It may be worth noting on the question of how many times do you keep going looking for T790M, that the response rate to, in the one trial that allowed these T790M negative was respectable. I think it was 23%, which unfortunately in our world is respectable. Mm-hmm. And so, you know, from a human perspective, how many times can you keep sticking until it's kind of absurd and cruel? On the other hand, you know, if it were me, I'd probably be tempted to stick a lot of times looking for T790M in that situation.
So thank you all for your time. We will break now. I will say that if we didn't get to your question, or if you have a different question that you didn't write down, the faculty here and many other faculty members will be around through the break. We'll be happy to talk with you.